Hello and welcome back, my dear students. Today we are gonna continue our new lecture on the pharmacology, that is for the second year students. And the topic which we are covering in the pharmacology is the anticoagulants and antiplatelets, and I'm talking about what these anticoagulant and antiplatelets are. Before we move forward to antiplatelets and anticoagulants, we must know how the clotting of the blood take place, and you must have studied in your physiology class also about the clotting mechanism. But still, when we are revising again these factors, and you can see that in absence of any kind of injury or any sort of impact on the blood vessels, the inner lining of the epithelial cells generally present in the blood vessels, they release certain kind of chemical messengers such as the nitric oxide and the prostacyclin. Now, the job of the nitric oxide is to dilate the blood vessel walls, and whereas the job of the prostacyclin is to bind to the specific receptors present on the platelets, which in result prevents the platelet activation or the platelet aggregation. And whenever there is an you can say the injury or the cut into the blood vessel, suddenly we have less of the nitric oxide and prostacyclin, and the blood vessels generally they constrict, and these binding sites which are preventing the clotting of or the aggregation of the platelets, they are less in number. But talking about are exposed to the collagen fibers, and these collagen fiber network, it tends to change their shape of the platelets, and these change shape platelets in return, now you can see that more platelets come to the site of the injury. Now, final step involves the activating of the glycoprotein 2B receptors, which in turn binds to the circulating fibrogen, and these fibrogens simultaneously binds to these receptors to link the platelets, that in results from the platelet aggregation. Now, there are several drugs which can disturb this clot formation or platelet aggregation formation. Collectively, we call them as the platelet aggregation inhibitors or the antiplatelet drugs. And most widely, which antiplatelet aggregation drugs you see, it is called as aspirin, which is most widely used. Now, for knowing how this aspirin works, we have to go back and study the physiology of the blood clot formation. And you can when we go back, we can see that when platelet is being activated, it releases the arachidonic acid. Then it gets converted to the prostaglandin H2 by the cyclooxygen 1 enzyme, also which is called as the COX-1. This in further is being metabolized to thromboxane A2, which is released from the platelet to activate the release of new platelets, as well as to promote their aggregation. So what aspirin do is generally it alters the formation, or it inhibits the formation of the thromboxane by inactivating the COX-1 enzyme. And then we have platelet aggregation inhibitors, which work on ADP receptor sites also by blocking their action, specifically when we talk about the P2Y12 subtypes. And drugs which belong to this type of drugs that belong to this class are generally clopidogrel, ticagrelor, ticlopidine, and prasugrel, that activate platelets. Generally, they release the mediator enzymes, and one of which is the ADP, leading to activation of the glycoprotein 2B and 3A receptors, which are required for the fibrinogen mediated platelet linkage. So by blocking the P2Y12 of the ADP receptors, these drugs generally they prevent the platelet aggregation, and resulting in non-formation of the blood clot. And next we have absciximol aptifabetide, and tyrofibin. These drugs generally they function by inhibiting the platelet aggregation by binding to the glycoprotein 2B and 3A receptors, and thus preventing the fibrinogen from binding to the platelets, making them unable to cross-link with each other. Now, the last group of these antiplatelet drugs which we are going to discuss are the phosphodiesterase inhibitors. Mainly the dipyridamole and the silistazole. These generally inhibit and alter the enzyme phosphodiesterase, which is responsible for breaking the cyclic AMP to the simple AMP. So by blocking these enzyme, dipyridamole increases the intracellular level of CAMP, which in turn results in decrease in the intracellular level of the calcium, and this automatically inhibits the platelet activation, as you might have studied in your blood clotting physiology. These drugs which we discussed, these are also responsible for the vasodilation. For this reason only, the silestazole, which is used to treat the symptoms of peripheral artery disease, such as when the arteries are being narrowed, narrowing of vessels of the blood system or the cardiovascular system, silestazole is main commonly used. Now, coming to the side effects of these drugs, it is generally a side effect. Major side effect is that it causes the bleeding. Silestazole, which is having the vasodilation properties, so it can also cause the headache also along with the bleeding. So going back, now you can see that accumulation of platelet only is not sufficient to stop the bleeding. A clot must also be formed, and for the formation of clot, as you studied in your physiology, involves a chain of reactions of enzymes that transfers the various clotting factors to their activated forms, and automatically producing the web-like fibrin mesh when fibrinogen is converted into the fibrin. And now there are two pathways which are involved in this clot forming factor, the pathways which you studied in your physiology, and they are the intrinsic and the extrinsic pathways. And we can see that in intrinsic pathway, which is activated directly by the damage to the blood vessel wall, and whereas in case of extrinsic pathway, which is activated by the trauma to the vascular wall as well as the surrounding tissues. And we can see in intrinsic pathway, which is it starts with the clotting factor 12, which is activated when blood comes in contact with the collagen fibers present in the damaged wall of the vessel, and is converted into the factor 12A. A generally here denotes for the activated form of the factor 12, and which in turns activates the factor 11, and which in turns again activates the factor 9, and after the factor 9 it turns into the factor 10, and this converts into the factor 10 activated form of the factor 10, acts on the prothrombin and it converts to the thrombin. Converted thrombin, it results and acts on the fibrinogen, and it converts into the fibrin, which forms the mesh which strengthens the platelet clots. This was the intrinsic pathway, and when we're talking about the extrinsic pathways, it is generally activated by the factor 7A, which again activates the factor 10, and after the 10A factor is activated, it again forms the same pathway and it converts the prothrombin into the thrombin, and thrombin it activates the fibrinogen and converts it into the fibrin. Details of this you can easily study in your blood clotting physiology. Now we have talked this intrinsic and extrinsic pathways, and this coagulation chain also we have studied. Now the drugs which work against this coagulation chain is called as the anticoagulants, and most widely used of the anticoagulants is commonly sees the heparin, and also some low molecular weight heparins are being used, which are in short form called as the LMWH. and example of these are the anaxaparin and deltaparin. And these drugs generally bind to our natural occurring blood anticoagulant in our body, called as the antithrombin 3, which inactivates the factor 10A and thrombin in case of the emergencies, so no blood clot is being formed. So this binds to the antithrombin and accelerates and increases its power, and activity of the heparin generally inactivates both factor 10A and the thrombin. Now low molecular weight heparins, generally what they do, they inactivates the factor 10A only. Another drug in this category which inactivates the factor 10A, and which is called as the fondaparinux, and but it does not have any direct effect on the thrombin. In same way, the some side effects which are there, but reversing is possible by a drug called the protamine sulfate, which works by binding to the heparin of the low molecular weight heparins to form the stable inactive complex by fondaparinux. In case of the fondaparinux, we don't have any kind of antidote, and the major side effects of heparin, you can see as you study in your medical surgical nursing. The major side effect of this heparin, it is the heparin induced thrombocytopenia, also called as the HIT in short forms. It is a disorder when our immune system start making antibodies to the heparin, and which it binds to the factor 4, thus forming the clump and clots, and patient may also die. There are other anticoagulants which directly inhibits the factor 10A. They are the apixaban and rivaroxaban. They inactivates the factor 10A, thus preventing it to convert the prothrombin to the thrombin. And the biggest advantage of these drugs are that they are found in the oral form, and in same way the side effects of these drugs are bleeding, and we have no antidote till now for these drugs. About the next group of anticoagulants, they are the direct thrombin inhibitors. Now how they, depending on how they interact with the thrombin, they can be subdivided into two classes. The first class is called as a univalent, which binds only to the active site prothrombin, and it is example of that are the agatroban and dabigatran. Now the second class is the bivalent class, which binds into yeah, which can bind bilaterally, and it is bound into the exosite 1. This provides high efficiency for the thrombin to form, and increases the efficiency of thrombin formation. And the examples of these drugs are bivalidine and dazuridine. And advantage of direct thrombin inhibitors over the indirect thrombin inhibitors is that they don't bind to the platelet factor 4, which makes them very useful in treatment of the immunodeficiency disease, which we discussed, the HIT, the heparin induced thrombocytopenia. And same way, the risk factors in these drugs is also the bleeding, and we don't have any kind of antidote to them. The oldest and most unique drug in this case is the warfarin, which you commonly have been seen in the hospitals. It is very unique in its action, as you know that vitamin K is required for the synthesis of various enzyme activities when blood clotting takes place, and vitamin K is required to synthesize the factor 2, 7, 9, and 10. These coagulating factors are inactivated, generally formed in the inactivated form in our body until they are carboxylated by the vitamin K, and this is reduced when we have reduced the amount of vitamin K available in our human body. Now in this reaction you can see that vitamin K is oxidized to vitamin K epoxide in presence of the oxygen and carbon dioxide, which in turn activates the clotting factors, and after the procedure takes place at the end, it is again converted back to vitamin K by the enzyme vitamin K epoxide reductase. And the warfarin drug which we are talking about, it generally acts on this enzyme only and prevents the vitamin K synthesis, and thus that reduces the clotting factor synthesis in our human body. And disadvantages, when we are talking about the disadvantages of these drugs, uh, the biggest disadvantage is that it has many drug interactions and food interactions, as it generally is responsible for the alteration in vitamin K. So for the patient on warfarin, it is very well monitored, and it is maintained as per the international normalized ratio, which is called as the INR. And antidote to warfarin induced bleeding can be stopped by vitamin K injection. Now, after talking about these two groups, last group we are talking about the thrombolytics. As all these previous groups, they inhibit the clot formation, whereas in case of the thrombolytics, they act on the active form of the clot which already has been formed, and they dissolves the actively formed clot by releasing the protein which is called as the plasminogen, which in return converts into the plasmin, which breaks the links between the fibrin molecules, thereby dissolving the clot. And the examples of some of the drugs which fall into the category of the thrombolytics are the altiplase, retiplase, and chenactiplase. These all drugs, they are artificially altered form of the drugs which are man-made, and also we have the natural form which is called as the urokinase, and from uro you can easily identify that it is occurring in the natural form in the kidney cells. And lastly, one more class is present, that is called as the streptokinase, which is derived from the streptococci bacteria. Place is more selective, and urokinase and streptokinase, these are the non-selective and can cause bleeding into the various other organs also. But the bleeding caused to the other organs by these drugs, they can be managed by administration of aminocaproic acid and or tranexamic acid. These two can stop the fibrinolysis by inhibiting the binding of the plasmogen, as well as its conversion to the plasmin. So this was all about the functions and formations and drug action modes of our three categories which we discussed: the anticoagulants, the antiplatelets, and the thrombolytics. And in summary, we are again revising all these in very short. Talking about the summary of these antiplatelet drugs, we can clearly see that they were divided into the first class of thromboxane inhibitors, which was the aspirin. Then second class was the CAMP enhancer, which was the dipyridamole, and the third class was the P2Y12 receptor blockers, which you can see it was a ticlopidine classes, and the final was the GP2B and 3A antagonists, and which was having the tyrofibon, and the thrombolytics, which we also discussed, are shown in this table as the streptokinase, urokinase, and the drugs which are acting against the thrombolytics are called as a anti-thrombolytics, and they are also shown over here. This is a summary table for your anti-platelet drugs. You can see in this next table of the anticoagulant summary, they are divided into the parenteral anticoagulants and oral coagulants as per their route of administrations. And the parenteral anticoagulants, they may be the indirect thrombin inhibitors, in case of we were discussing as the heparins and other low molecular weight heparins. And then there are the direct thrombin inhibitors, which was the lepiridine, and then in the oral anticoagulants, we were discussing the coumarin derivatives, which was the warfarin, and then there were the direct factor 10 inhibitors and the direct thrombin inhibitors. So these tables are very helpful for your exam purpose also, and for your remembering purpose also. You can keep these tables in mind, and you can easily remember all these anticoagulants and antiplatelet drugs. That's all for today's lecture, and see you in next lecture. Thank you.